We are going to admit a patient. We'll make up a chart. Will usually be, the paperwork will be contained in this file here. So we'll start with their chart, and this has all of their whole signal mint and everything on paper. So their last name, the client's name, address, phone number, the patient's information. So you have their name, sex, birthday, ID number if they're microchipped, what color they are, the species, dachshund, breed rather, age, their rabies tag number, and their weight. It will have any alerts that we should be looking at. If they have a heart murmur, if they're diabetic. This one has a caution for muzzle, back pain, careful when picking up. It has a list of their wellnesses, so their vaccines, when their last blood work was done, their heartworm tests, their annual, their fecal, what they're here for today or what their next appointment is usually the day of the procedure that it's printed out for. And then we have a summary of diagnosis codes that they've been diagnosed with, so we can quickly scan over them and make sure that anything that might have been missed in the alert, like they were diabetic or they have a heart murmur that was not listed on their alert. It also has the weight history listed in a range so that you can see if they've been losing weight consistently, if they've been gaining weight consistently, if they've been completely normal. The rest of the chart is in the computer. So this will be here. This is the rest of their chart. You can look through anything and see what medications they've been on. I'll say Smokey because he's had some medications, he's had dentals, so it can list your his whole history. For Katie, anything that was recorded before they came here, you can see their records received. You go to the attachments, we scan them in. If they're emailed to us, we put them right into the file through the email. If they come as a fax, we just scan them in. Our cage cards are here. Our cage cards will say what the procedure that they are here for, whether it's here, whether it's for hospitalization for IV fluids. So depending on what the cage card, that is one way for us to know. The cage card will say with their paperwork, it will be on the cage, there'll be one with their leash and collar. When we are looking to see what is done, we'll take the chart. The chart will be on their cage. Their anesthesia report goes right on their cage as soon as they bring them back. We do the math immediately, put it right on their chart, and it goes right on their cage. We check all of the identification, make sure that everything matches, what they're having, who the patient is. There's also a collar that goes around their neck that has their name on it, their phone number, and the procedure that they're having done. So this way we know that these are all little checks that we can make sure that they're getting the correct procedure while they are here. Their treatment plan. There is 2 copies of the treatment plan, one for us to have get signed from the owner, and one to go home with the owner. So this has the owner's name, the patient's name, our hospital, and then it just tells you about what they're going to get done today. So in this case, it's a dental cleaning and polishing, and it lists everything: the IV catheter, the fluids, the pre-anesthesia, the dental anesthesia, SIVO, our anesthesia monitoring, our whole mouth X-ray, our hygiene pack, our sterile pack, dental and probing, fluoride treatment, nail trim, our temperature controlling device, biohazard disposal charge, our hospital charge, if any, and then down here becomes if we had an extraction, if there are any extractions, these charges are then brought up. So then we'll explain to them that this is the 1 root, and these are per tooth. So per 1 root extraction, it will cost $24.30. Per 2 root extraction, $52.65. Per 3 root extraction, $57.15, etc., etc. If they need oral sutures, depending on the tooth that's removed, pain management, injection, and two additional days worth of medication. It gives a variance of the fee that'll be charged between this or this. It gives them all of their reminders so that if they needed their heartworm test while they were here, if they needed a vaccine while they were here, if they were well enough at the end of the procedure or when they were awake, they could have it done. If they wanted a microchip, we give them another chance to do that while they're under anesthesia. We talk about advanced directives, whether or not they want us to do CPR or not. We'll do everything possible to maintain their health, understand that their signature below indicates that you've reviewed and agreed to the terms of this estimate. Your signature below does not make you responsible for the charge, your signature below does not make you responsible for the charges listed above unless performed upon Joey. So just so they know, and then that the payment is fully required in full at the time of discharge. Okay, let's say that again. And this tells them that the payment is required in full at the time of discharge. So we'll have them initial that, we'll have them sign here, give their phone number that they can get in touch, we can get in touch with them at. In some cases, we'll call them during the procedure to see if they extract, to let them know how many extractions are coming out, and so that we can go ahead and proceed with that. So we want to know the best number that we can reach them at in that case, or in case of an emergency during the procedure. So they will get a copy of that, they will sign a copy, and that will get scanned in the records just like the previous records get scanned in. Then if any additional blood work or additional work is needed, actually any of the forms that might be needed. So this is our IDEX, we sent them out for blood work, so this is blood work results on one of our house cats. So we look through their blood work and make sure that it's safe for them to go under anesthesia. If they have a heart murmur or sometimes a specific breed, maybe a boxer or a Cavalier, King Charles Cavalier, we might have them do an ECG report. So we might do a pre-anesthetic ECG. We use an Alive Core system, so we have an Apple iPad and a device that we place on the heart with the patient in right lateral recumbency. We get a readout onto the Apple iPad. We then fax it to Red Bank, to the cardiology department at Red Bank, and they read it for us and give their recommendations. We let them know what anesthesia we're using as a pre-med, what we're using to maintain them, and then they send us back a report on whether they're okay. Despite the murmur, it appears from clinical description of the chest films, the heart is not enlarged. Chronic valve disease in dogs with no enlargement typically make good cardiac patients. So this dog was okay to go under anesthesia for his procedure. If we had x-rays taken before the procedure or after, we might send them out to the radiologist. So this is our history of the procedure, our patient's name, species, breed, etc. is up here, and then this becomes the report, what they found, what they concluded. And if we have an ultrasound done before their procedure, this is about that. So this is the findings that they seen on ultrasound, and then this is the conclusions that they reached from their findings while they are under anesthesia. We use our anesthesia forms. So we'll have the patient's name, client's name, feline, we have feline and canine, their sex, age, weight, date, procedure, vet verification and nurse verification, so we both initial. Any medical alert information, so if they have a heart murmur, if they are diabetic, if they have any Addison's disease, anything that needs mentioning during or before the procedure. The pre-anesthetic exam, the technician will do beforehand, so their CRT, their heart rate, respiratory rate, temperature, the IV catheter size and location of it, the medications that you were using for pre-meds. So for cats, we'll usually use the dextromethorphan ketamine torbagesic combination. Buprex SR is what we use if they need pain medication. Buprex SR lasts for 3 days, so we'll tell the owner that as well. What we're using to induce, if anything, the IV fluids, their rate, and how much they received at the end of the procedure. Anesthesia start time and finish time, the procedure start time and finish time, and any antibiotics that they may have gotten, the name and mLs, and at what time they have been given it. Whether or not they were intubated, and if they were intubated, the ET tube size, what time they were intubated, what time they were extubated, and whether they used a rebreather or a non-rebreathing system. We only have 1 liter per minute for our oxygen. We don't have a 2 liter system. We only have a 1 liter system. So our oxygen will always sit here or below, and then whatever our sevoflurane we have them on, we'll decide based on their anesthetic what sevo we will be on. Our ER plan, so our emergency drugs, we use atropine to start with. We'll have a dose of epinephrine and lidocaine. As soon as we have the patient's weight, we'll do the math and figure out what they would be getting, and if they get it, what time they have gotten it. So to monitor, we monitor their blood pressure, their pulse oximetry, their capnography, active warming device, depending on whether they're in the OR or they're out of the OR getting a dental in the treatment room. They'll either be on the OR table for the warming device, or they'll be using the chili buster blanket. We have an IV warmer that we use in either place, EKG, and our breath safe, which hooks up onto the E-tube as well. And then here are all the codes for the heart rate, respiratory rate, SpO2, mean blood pressure, EtCO2, and temperature, and the quality of their sedation. So while they're being monitored at the end, you'll note whether they were overall light, moderate, or profound. And then, of course, the post-anesthetic vitals. So once they're off of anesthesia and starting to recover, we'll take their time, the time that it was taken, their temperature, heart rate, respiratory rate, mucous membranes, and their CRT. Whether or not they're sternal or ambulatory, their pain score, and the initials of the technician or the assistant that has taken those. Sometimes it's done while they're recovering, sometimes it's done a few minutes after they're recovering while they're back in their cage. And then we have our home care instructions. This one is for a spay. So we have the ovarian hysterectomy was performed. We use a laser here. So we talk about the technology reduces trauma and improves recovery and reduces postoperative discomfort. The proper follow-up care is essential for successful recovery. We talk about restraint and staying quiet and loving while using proper restraint to make sure she doesn't engage in too much physical activity. For the first 12 to 24 hours, they may be quiet and sleepy. For the next 10 to 14 days, we try to restrict her activity as much as possible, limit her running and jumping, leash walks outside only to relieve themselves. I'll usually tell them don't let them chase a squirrel across the yard. The more quiet time in the crate, the better for the next week or so. Food and water, I'll usually tell them when they go home, let the patient settle in for an hour or so, and then offer them a small amount of water. Just like with humans, anesthesia might cause some digestive upset, so we just want to limit the amount that they might vomit if they do at all. If no vomiting occurs after another half hour, 45 minutes, you can offer them a small amount of their food. Just go very slow. Tomorrow she can resume her normal feeding schedule. Pain management. Pain medication was administered preoperatively today, so don't give any aspirin or Tylenol, etc. to over-the-counter pain medications can be toxic when you're sending home with non-steroidal anti-inflammatories to relieve any discomfort you may have. I usually will tell them that aspirin or Tylenol or any kind of steroids can cause an ulcer in their stomach when it interacts with the Rimadyl that she's getting. I'll go over the dose and give 1/2 tablet by mouth once daily, every 24 hours in this case, for post-operative comfort, and when to begin it. So I'll tell them to begin it tomorrow morning in this case. Her sutures, the incision will take about 10 to 14 days to heal. Just monitor incision over this time. Some slight redness and swelling is normal. Anything excessive swelling, redness, please give us a call. We discussed the e-collar if they aren't already going home with one, so preventing self-injury. She may harm herself by excessively licking or chewing at her incisions. I discussed how they can open their incision and she might have to come back in and go under anesthesia to have the surgery, the incision closed. So please be careful and watch her, and if she exhibits this behavior, it might be necessary to fit her with an Elizabethan collar until the incision is healed, which they can get from us at a nominal cost, or they can get it from a pet store at also a nominal cost. I also tell them that if they are in the middle of the night and they're stuck and they really need to keep her away from it, to put a t-shirt on her and tie it at the hip. That'll usually work for a couple of hours until she realizes how to get around it. So they might get them to the morning to get to the e-collar. But obviously getting it beforehand is much easier to have on hand than to need it and not have it. I'll tell them reasons to call us. We'll discuss most people are fine after surgery, but anybody who underwent anesthesia should at least be monitored. So not drinking for more than a day, any obvious pain or tenderness after 2 days, depression, discharge from her incision, not eating for more than 2 days, any lethargy or weakness, or anything that worries them, so please give us a call. These are our office hours and our phone number. Gizmo did very well while she was here. She's a very sweet girl. She received 2 injections of pain medication. We'll tell them what they are. Which will last until tomorrow morning. You may begin her pain medication then, which is the oral Rimadyl, as directed, and then I'll go over their home care. Their technician will see them back in 10 to 14 days to make sure the incision healed correctly, as well as take the sutures out. We just have a form that the technician has reviewed my pet's discharge instructions with me, and I understand these instructions to please sign, and the technician will initial as well, just to make sure that we know that we went over the home care instructions with our client. Okay, so we're going to show how to properly restrain for a blood draw. So on a cat, you can hold his front legs in your hand, pull his head up, and make sure it's completely straight and even with his body, so that it is all in a formal straight position. Another way you can do it is hold him over the side and pull his face up like this, so the technician can take the blood. Or, if they're very good, you can hold them up like this, and that'll depend on if they're going to use their feet. And that is for jugular draw. For a cephalic pain, you're going to, maybe, it's okay. You're going to place your hand under his chin, and you're going to take his arm and roll his vein slightly while holding your other middle finger behind his elbow. So this way it is extended, and when they put alcohol or they clip the area, they'll be able to see the vein come up. And for the saphenous vein, back of the leg, it's okay, baby. You're fine. You're fine, baby. You're okay. You're okay. For a cat, you can scrub him. You're going to take his leg, you're going to pull a little bit of the fat or skin upward, and then you're going to apply pressure. You take his tail, move it into your hand as well if he starts to use that. And then the technician can take blood out of his back leg. And that is the 3 ways to take blood on a kitty cat. All right. When you take a patient, put him in a cage, you want to make sure you support him. Lift them into the cage, and then they can go and lay down. Okay, we're going to take Ashley out from the cage. We're going to take him, scooch him towards us. We're going to have his head held, and we're going to make sure we hold his inner foot so that he cannot reach around and scratch. And if you have his head, he cannot reach around and bite you. And you're going to have him tucked under your arm so he feels secure and giving him less reason to fight and resist you. Right, so go. Proper muzzling. You're going to take the muzzle and you're going to come up over her nose. And you're just going to gently apply it and go around back. And then you're just going to make sure it's nice and snug around her neck. Good girl. Okay. Ashley's going to demonstrate how to apply an e-collar, or is going to be my guinea pig. I have the e-collar already made. You're going to slip it over his head, watching his eyes and his ears with little flaps. And then you're going to tie the tie. You can use his collar. You can use a piece of the stretchable gauze. In this case, I just have a piece of medical tape folded in half. When you're using something like medical tape, you want to make sure that, that it is not too tight. So you want to be able to get 2 fingers underneath it. And you want to make sure that it surrounds his nose appropriately so that he can't turn around and get his sutures out or pull his catheter out, or whatever the reason that he has the e-collar on. We're going to do our physical exam. This here is Emily. Emily is a 6-year-old greyhound. She's going to be coming in for a dental cleaning. Right. Eyes are beautiful, very moist, not pushed back in her head. Capillary refill time is good. She does have tartar on her teeth. Right. Good girl. Beautiful. Look at your ears. Not bad. Check your lymph nodes. Good. It's okay. You're a good girl. Good girl. Good girl, right? You're a good girl. Okay, we're gonna listen to your heart and your lungs. It's okay. No smell. Good girl. And also check her pulse while I'm checking her heart rate. Good. Very good job, Emily. Very good. Just gonna feel her belly. Good girl, right? You're a good girl. And a good girl you are. Good. Oopsie. One last thing, baby girl. So to check your temperature. Steady. Blue. Good girl. Good girl. Good. Temperature is perfect. 101.3. She is in good physical condition. She is a body condition score is a 3 out of 5 or a 4 out of 9. She looks great. Everything about it looks great. I would give her ASA graded 1. Okay, this is Ashley, and he's going to have surgery this morning. Ashley is our house cat, and he is diabetic and hypothyroid. His blood work came out fine, so we're just going to do our physical exam on him. No, my dear. Okay. 9:20. Just gonna take a step real quick. Right, my dear boy. Let's just go boy. Perfect. His temperature is 100.3. So Ashley is ready for surgery this morning. And draw blood from the cephalic vein of a dog. I just need a small amount for her hematocrit. Cephalic. Couldn't take the blood out of the cephalic vein very fast. Alright, so we're going to do a jugular vein. We're going to apply pressure right in here. And allow it to pump up a little bit. Jug stick on a cat. Ready?
Recording.
Getting blood from the lateral saphenous vein. She will now bleed, which is just pushing it to the side. Nope. When we draw our kitty cats come back, we're going to draw blood on her medial saphenous vein. Double up. Not much, but a little. For the minimum database for the book in TARE, it's going to be a PCV, total solids, a blood glucose, a BUN, and an ALT. The PCV tests your red blood cell production. The PCV tests the movement of fluid into and out of your cells. The BG tests your blood glucose for that period of time that you're taking it for anyway, and your ALT test is a liver function test, and your BUN is a kidney function test. So those are a minimum database discussed in the book. In our practice, our minimum database would be any patient under 5. If you're going through a procedure like a spay or a neuter, even a dental under 5 years old, we would do a CBC. If you have a heart murmur, of course, there might be additional testing like an EKG or radiographs of your thorax. If you're a patient over 5 years old, we're going to do a Chem 10 panel, a CBC, and lights, just to check your basic functions. make sure everything is going well before we put you under anesthesia. If you are, if you're going under anesthesia for anything else, say you're sick, you're vomiting, there's a lot of things going on, you might have your blood work, your Chem 10, your CBC, and your lights. They might do a Chem 17 panel if you're really ill. They might do radiographs, EKG, depending on if you have a heart murmur. Even if it's just from dehydration, they want to make sure that you're okay before you go undergo anesthesia. Those are all the extra tests that you might find as a minimum database, depending on the severity of your illness. Okay, so we are going to discuss our patient. Zara is her first name. She is a husky mix. She's a smaller breed dog, even though she's a husky mix. She's only 33 pounds. She is going to be spayed today, so we are going to discuss her anesthetic and peri-anesthetic protocol. She is going to start off with her ACE, promazine, and torbagesic. It will give her a sedative effect and also provide some pain management along with the opioid, torbagesic. She'll then be induced for her anesthesia with propofol. And then for her pain management during the procedure, we're going to give her an injection of Buprenex, and as well as a 24-hour dose of an injection of Rimadyl. That should keep her anesthesia level at a minimum, the amount of gas that she's on during the procedure, and also will cover her peri-anesthetic pain medication, will also cover her post-anesthetic recovery. And since it's a 24-hour dose of Rimadyl, we give a 24-hour dose in case they're not hungry or they're not eating later in the day. They can still, they'll still have pain medication on board. Okay, we're going to put an entry in the logbook for this logbook is for torbagesic. And this is going to be our entry. We're going to enter the last one. The patient's name is Ebony Westfall. I'm going to put the patient's phone number, 713. The bottle number, which is bottle 200. The amount that we are giving. And then the total. And then we're going to sign it. So here's the last entry. We did it for 326. Ebony Westfall. This is her phone number. This is the bottle number of the torbagesic that we're using. We're giving her 0.10. We decreased 0.10 from the 0.565, making it 5.55, and we added our initials. And that is for the torbagesic logbook for 2018. Our oxygen is housed in a shed outside. These are our oxygen tanks. They are they have the 5-foot tall tanks. This tank is full. It leaves the tank, this valve is open. It comes out through these hose. It comes out into our box. This is our line pressure. It then comes through into this part here, into this piping here, and up in here through to the building. We have a passive scavenging system, and every day after surgery it gets weighed to see how much waste anesthetic is in it. It only holds about 50 grams of waste anesthetic, so after that it is full and no longer can accumulate. So we just weigh it every day to see how much gas has accumulated. This one is a brand new one, so no gas anesthetic has accumulated in it yet. Oxygen leaves the oxygen tank, travels through the tubing, enters the back of the flow meter at the bottom. When you turn the flow meter on, oxygen travels through the flow meter, exits the top of the flow meter, and enters, picking up anesthetic gas when it enters the vaporizer. It leaves the vaporizer, entering the inhalational valve. Some of the anesthetic gas will go into the bag, some of the anesthetic gas will go into the inhalational tubing, which will then go into the patient. When the patient exhales, the anesthetic gas, the waste anesthetic gas will enter the exhalational tube, go through the exhalational valve. Then some of the waste anesthetic gas will go into the carbon dioxide absorber, removing the carbon dioxide. Whatever has gone into the carbon dioxide absorber will then enter the inhalational valve. Some of it will fill up into the reservoir bag, some of it will fill up into the inhalational tube, entering the patient without carbon dioxide. Another portion of the waste anesthetic gas will leave through the relief exhaust valve and enter into our anesthesia absorbing canister. By some of the waste anesthetic gas leaving through the relief exhaust valve, it allows the machine and the lungs to maintain equal pressure of 1 to 3 centimeters of water. So now for the non-rebreather, tubes, the non-rebreather gets hooked up directly to the vaporizer and directly to the anesthesia absorbing canisters. The oxygen is going to come in the same way it did from the bottom of the flow meter. It's going to leave the top, it's going to travel through and enter the vaporizer, picking up anesthetic gas with oxygen. However, this time it's going to go directly into the inhalational tube. Some of it's going to enter the reservoir bag and some of it's going to enter the patient. Whatever the patient exhales is going to leave the exhalation tubing, go directly into the anesthetic absorbing canister. This is to ensure that the patient gets fresh anesthetic gas and fresh oxygen each time he takes a breath. There's no recycling of any of the waste anesthetic gas in a non-rebreathing system. It's usually used for patients under 7 kilograms. Okay, for the induction chamber, it'll be a small box. It'll have a spot for inhalational tubing and exhalational tubing so that you can provide anesthetic gas to either a cat or any small animal, rabbit, rat, mouse. The chamber itself fills with anesthetic gas, inducing your patient with anesthesia, and then you can take them out and intubate them. Some of the other things that we'll use for inducing anesthesia will be possibly a mask if the patient isn't down enough for intubation. You have the cat or small animal mask and a larger dog or small animal mask. They can also be used to help the patient breathe if they're having difficulty while they're here. Different E-tubes, and these are going to go down their throat. The cuff steels, blow the cuff up, and the cuff steels in their throat so that they have a nice seal, allowing the anesthetic gas to do its job and keep them sedated. E-tubes also determining what size to use and what patient. There is a weight chart you can use. It does come with some experience. A 2-pound animal per se might use an E-tube anywhere between 2.5 and 4. A 5-pound animal may use anywhere between a 5 to a 6 millimeter endotracheal tube. Cats, you wouldn't really use anything above 4.5 in a cat, unless it's a very large cat. But in regular domestic short hairs, you'd mostly use a 4 to 4.5, 3.5 if they're smaller. Okay, so we're going to test our anesthesia machine. The anesthesia machine should be tested every morning. Ideally, in a perfect world, it's tested before every procedure. However, if that is not possible in your hospital, then it should be definitely tested every time you change the machine, the tubing or the bag. So we're going to close the shut-off valve, turn the oxygen on. We're going to seal the tubing using our hand, and we're going to press the flush valve. It's actually a little flush. So we're going to press the flush valve till the manometer says 20. Your bag should be nice and full. You should hear no hissing, and it should maintain at 20. You're going to turn your anesthetic gas on just the slightest bit, just opening and closing is fine. That's just to make sure that this part of the sealed system also is closed. Then you're going to open your valve while you still have the whole system sealed so that you don't forget to open your pressure shut-off valve. You can turn your oxygen off, then you can release the air. Okay, so this is Luna, and so she is hooked up to her EKG leads. So the white one goes on the right arm, the black one is attached to her left arm, and the red one is attached to her left hind, sorry. And that is her EKG up there, which is great. It's very strong, steady, even beats. Then you have her SpO2 that is attached to her tongue. It reads the amount of oxygen she's saturating. She's at 99%. It also lets you know about the pulse, and that is here. Her E-tube also measures her respirations and her EtCO2. And that's just the amount of carbon dioxide that she is exhaling, and the inspiration is actually, okay, is better now. Her respiratory rate, she's waking up, we just finished surgery, so it's a little higher. We also have her temperature probe, which is in here. It is, her temperature reading is down here, which is 99 degrees. Not bad for... Okay, the other tube in her mouth is the endotracheal stethoscope, which you listen through here, and her heart rate is great. It sits right next to her heart. You can hear her heart sounds and her lung sounds throughout the entire procedure. She has her IV catheter in. She gets IV fluids. And this over here is her blood pressure cuff. This monitors her blood pressure. And this is her blood pressure at the moment, so it's 66 mean, 88/47. This is a history of her blood pressures during surgery. And she's getting... Lynn, this is my preceptor. She is my certified veterinary technician and my supervisor. Looking up for a catheter. The rule of thumb is 2 clipper blades away from the vein. And then put her all the way around. Such a good girl. Okay, first I'm going to take my hexadine scrub. Alcohol rinse. Okay. Good girl. The first piece of tape is going to go tape side up, sticky side up, and around the hub. The larger piece of 1-inch tape is going to go under, sticky side down. Neosporin and the bandage. The catheter site. And then I take our stirrup and put it on here. And then I'm going to take my bandage material. And then clean. You're just going to work very well, but you're just going to pull it a little bit taut. And then your vet wrap. You're just going to lay flatly and not pull too tight. And I'm going to get my flush. Good. And put 2 cc's of flush in it.
Go.
All right, we're going to do a catheter in the medial saphenous. And this is the chlorhexidine. And this is the alcohol rinse. First piece of tape is going to go sticky side up underneath the hub of the catheter. Larger 1-inch piece is going to go sticky side down. Some Neosporin, some gauze, some telephone. That right at the injection site. stirrup, put it around the catheter. Here. This is flush. Very good. 2 cc's added. Small amount of bandage material. Kind of sticks to my hand a little bit. And the port is still available for intravenous use. Injection of convenia. Just want to pinch the skin up, some little space, draw back, make sure there's no blood in it, and then inject. Give the intravascular injection up here. I'm sorry, Nick. Ready? 1, 2, 3. I'm sorry. I'm going to do an IV injection. We didn't do Scarlett for her dental today, so she's been on sevoflurane for a few minutes. She was on oxygen, pure oxygen first, and then we switched her over to sevoflurane. But you didn't go. See the bag moving. You can see her breath in there too. I'm going to take the string, I'm going to tie it, and I'm going to pull it back over her head to tie it in behind her ears. And that's going to hold the tube in her mouth. I'm going to take her pressure cuff, the cuff, and I'm going to fill it up. So there's just a little bit of back pressure. Don't want it too tight. I want to feel it's a little firm. Now her SpO2, so we can begin to monitor. And then I have her eye move.
Started.
All right, we're going to clip Luna up for her spay. She's going to get clipped from the xiphoid process down to her pubis.
Can I throw you these? You just throw them on the shelf in there? Or
Yeah, well, yeah.
And there's the other two like that. Just throw them anywhere. think they were matted. She was just messy, so we did a little extra. You can vacuum. I'm gonna express the bladder, all of our extra hair out of the way. See, something always goes wrong. Just hold her tooth for a minute. I'm just gonna pull it down. measurements. And then here we do another scrub in the OR, so she will be scrubbed again. Once we're transported.
I don't think that would be appropriate.
alcohol. Instead we use the soda water.
Is it?
It's for Amanda, she's a feline, we're spaying her, she's in the process of being spayed today. This is her SpO2 and her temperature. As you can see, her SpO2 and her temp is the sideway arrow. Her heart rate has been the closed dots, her respirations have been the open dots, and her EtCO2 has been the X's. And her blood pressures have been the lines. She's been on 3 the whole time of the procedure, and her oxygen is on 1 because we have low flow oxygen here. She has a 4 E-tube, and we intubated her at 820. She'll be extubated shortly. She got her pain medication. These were the pre-meds that were used, and you can see up here that everything pretty much coincides. The respirations, the EtCO2, her oxygenation, and her current blood pressure, along with her temperature. Okay, if my patient was to go under respiratory distress, you could use the machine itself as an ambu bag. We have a safety relief switch over here that we can include and then squeeze the bag down to give them a breath. Or we could use the ambu bag, and the ambu bag hooks up to the E-tube, so you would just replace it with this, and then you would give her short breaths, as you did CPR on her. Okay, so I did my pre-surgical scrub with chlorhexidine soap. I'm going to do my surgical scrub now. First I'm going to take my nail file, nail pick. I'm going to make sure all underneath all my nails are clean, any debris, any soap, anything. I'm going to take my hypodermic scrub soap. It comes pre-packaged, it has soap in it already. I'm going to start scrubbing all of my fingers. It's a 5-minute scrub time, or you can do 10 scrubs on each side. I'm going to do 10 scrubs on each side. Each finger has 4 sides, plus the tip.
arms and your elbows. You're going to keep your hands elevated so that the soap is not running down onto the hands. Off the soap and the sponge, and then you're going to rinse your fingers slowly. You need to go up your arm, and as you go up your arm, your hand is going to be elevated so that the soap does not go, the soap from the elbow does not go to the hand. Same with this arm. All the way to the elbow. And you're going to rinse off, and the assistant will turn the water off for you. Okay, and now my surgical gown is open for me. The OK strip, I'm just going to make sure that it is considered sterile. That can go to the side, and then I'll take my towel, and I will dry each finger. Individually, you just want to make sure that everything is dried. Thoroughly so that no you're going to take a second section of it, and you're going to dry with this other hand. Third section of it, then you're going to clean the forearm, dry the forearm. And you're going to take this side, come over here, and dry that forearm, and then that can go over there. You're going to take your gown, and you're going to put it in. Slide it on without your fingers coming through. I'm going to have it fit as best as possible before the technician ties me in. Both of my hands are still in the glove, in the gown, so that I can do the closed gloving. I'm going to take this black gown, I'm going to put the gown inside the glove. I'm going to slowly pull it on so that my hand comes out of the gown inside the fingers of the glove. Now once that one's on a little bit, I'm going to do the same with the other one. So that I don't risk contamination or my fingers coming out of the gown. And then I slowly pull out the gown down. And it's still on my hand, but not constricting my ability to move them. And then I wait for my assistant to come in, and she will tie me in. And here she is. Okay, so I am fully tied in. My scrubs aren't showing, my hair isn't showing. I'm going to keep my hands here until my drape is opened. She's going to open my drape, and then I'm going to help to assist the doctor with the surgery. Not even sure how this is gonna go. Okay, so we're setting up for our spay. And our OK tag. Likes his larger hemostats in the back. Additional is a little taller than me, so the table's a little higher. commercial drivers. The doctor.
Actually, forceps first.
The duties of a sterile technician would be maybe helping the doctor hold the abdomen open if necessary, blotting excess blood or any kind of fluid in the abdomen or in whatever procedure you're doing, passing instruments to the doctor, kind of being a third hand or an extra set of hands actually in the surgery. All of those things are helpful to not only speed up the surgery, but make the surgery itself more efficient. If one of our instruments were to fall on the floor during the procedure, we would simply have the assistant pick it up. If I wasn't a sterile technician in there, I would just pick it up myself. And or if it was definitely detrimental to the surgery and we didn't have a spare one, we could do a flash sterilization, which is simply where we put it in the autoclave. So we wrap it, put it in the autoclave for 10 minutes, sterilize it, and then move on with the surgical procedure. Okay, so depending on if I have a glove ripped during surgery, in order to not break sterility, I would have the technician take my glove on either side and hold the gown, which is underneath the glove, and they would pull it on both sides so that my gown came back over my hands, and then they would take the glove away. This way my hand is still in the gown, covered, and then I would use the closed glove method again to place my hand in a new glove and put that on. Once you are sterile and you're in your gown and you're all, you have your gloves on, this is the portion of you that is going to be sterile. So you're going to keep your hands up. You're going to keep them tucked into you, to your sides, so that this way any of the movement that's going on, your hands aren't out there waiting for somebody to bump into. You're going to keep your front half towards the table, you're going to keep your front half towards the patient and their sterile field. You're going to, if you do have to pass the doctor, you can pass back to back so that neither one of your sterile fields are jeopardized. By, say, the back of an elbow or the back of an arm as you're passing them.
This is a cat spay.
This is a dog neuter.
For cleanup, we will usually take our sharps, we'll take our needle drivers again, and we'll lift the bottom of the blade and just slide it upward. And the blade will come right off, we throw it right into the medical waste bin. And the same thing with our needles from our suture material. It is a little magnetized, so it will stick to it. Okay. Okay, so when we're cleaning the OR, we will take our bucket of water, and we usually make it a 1:64 ratio of rescue and water. Put this over here for now. And we wipe everything down, everything gets wiped down with this and allowed to air dry. So anything and everything gets wiped down from head to toe every day at the end of the OR. In the beginning of the OR, we will do a quick wipe down before we set up for surgery. But at the end of the day, everything gets wiped down. Head to toe, wheels, tops of tables, middles of tables, wheels. All of the lights will be cleaned. These will all get cleaned all around them, up on here so that there's no dust. Any windowsills, these countertops, the baseboard heating, the bottom of the anesthesia bins. So everything, all of these things will get wiped down every single day. We have the laser machine, we have the monitor, everything gets wiped down from head to toe. Laceration pack, which we ran through an ultrasonic cleaner. I run it through for about 15-20 minutes. Take all of our instruments and open them up. These are the towel clamps. The scissors, I make sure there's no blood or debris on anything. If there is, I scrub it off. This is for our pack wrap. This is a laceration pack. There is blood in this one. So we take our wire brush. So our laceration pack is a smaller pack than a small pack or a large animal pack, because most of what we need just for laceration repair or any kind of wound repair, dog bite, cat bite, and then I'm going to spray on the surgical spray into all of our instruments, and then let it sit and dry. And then as that dries, part of our laceration pack, we also use a drape. So we're going to fold this accordion style, just as I would a normal drape. And it can be opened. In surgery by the doctor. Back and forth. Tab is left over. Now for our laceration packs, We put the hemostats in size order. And through the end of them, we put the mesomob scissors and we put the largest hemostats. And we make sure that none of them have clamped down so that they all become sterile during the sterilization process. Okay, everybody's sitting beautifully. Then we put the towel clamps in size order. And we do the same with the needle drivers and the Mayo scissors. And we neatly sit these onto the drape. We put our forceps on one side and our needle scalpel blade holder on the other. And then take an outer surgical wrap along with our inside drape. And our drape goes down flat. Take these, we put them inside. Our biggest concern with all of the instruments is that they don't poke through to the outside. We're going to get 2 packs of gauze. Sorry. And it is also going to get an indicator strip so that the doctor knows once they open the pack. On one side is a dot, there's a dot here that'll color in black, and this one is an O, and the K with an arrow will color in once it is sterilized. So I will put this in here. I'm going to start to fold it top down. And the reason I fold it top down first is because when the doctor opens the pack, he's going to open it bottom down, and he needs to open it to him first so that his gown does not touch the table that it is on and has protection. Bottom up. That gets done in accordion. And then this also gets done in accordion from side to side. Accordion. Okay, so what I gotta do. It's gonna be about so really a little tab up here. To do the same thing. An accordion, we have a little tab up there. Accordion. Up here, and then I pull these 2 taut. And I flip this over, pushing at the same time to make it nice and snug. Tuck this little thing in here with the flap sticking out, and then I'm going to take my tape, and the tape is also indicator tape, so pull that all the way around, and that just lets me know that the entire, once it goes into the autoclave, it lets me know the entire package has reached the temperature. Laceration pack, we then label it. We write SL because we surgically lubricated we spray lubed the instruments. And then today's date is 1/22/18. And each surgical pack is good for 6 months, so it is good until 7/22/18. And you must initial it so you can know who did it. It's a laceration pack. We SL'd. Here's our date, today's date, and my initials. Okay, so our gown is going to get wrapped inside out. So this would be outside in. This is inside out. And the hands and arms are in. We're going to take, and it's going to be wrapped in accordion style. So we take it like this, and then we fold it on the table. Tuck the arms in and make them nice and flat. Everything just has its place. It's very flattened. And then we will fold this side in like this, and the other side right under. We'll fold this side in like this. Okay, and then we'll have an accordion in the other direction. So accordion this way, this way. Okay, and then it becomes an accordion, and the doctor can just lift it and pull. It comes right into its space. We wrap our doctor's gowns with a towel. And then it is going to be the same envelope pattern that we had for our pack earlier. This is going to get pulled through here. And this is our indicator strip, so that when the doctor opens the pack up, or when the technician opens the pack up, she can see right away what the indicator strip will show, whether or not it is sterilized. All this one. Forth until you leave the tip revealing, so that you can pull that piece later. Tuck this in and this in. And tuck. I leave it flat in all of my indicator tapes, but in this case you don't need to because the outside is discarded when we open the other wrap. So, and then again we label. In this case it's an extra large gown. 122 to 722. 18. And my initials. For an extra large gown. The date that they did it today, it's getting on the plane right now. 722 and my initials. This is going to go in with the afternoon surgeries. There is a pack in there again, so I'm going to pick pack, 250 degrees for 30 minutes with a fast vent dry. I'm going to start. Okay, after all the work pre-soaking and pre-cleaning and decontamination, it's time to autoclave our packs and our instruments. And an autoclave works by building pressure and temperature. Once the temperature rises, the pressure increases in the unit, and the pressure pushes the steam into the packs, around the instruments, killing any living microbes that are left on after all of the cleaning that we have done to them. Depending on how tough it is to get into the packs, depends on the length of time that your autoclave cycle is going to be for. So to get into our packs, it's going to be at 250 degrees for 30 minutes. If we were doing unpackaged items, it would be 250 degrees for 3 minutes. So it all depends on how much pressure you need to get around all of your equipment. Okay, so when you pack your autoclave, I just used some of the packs that were already sterile, but I just want to show that I want room left here at the top. I want the steam to be able to get into all of this and really sterilize our equipment properly. You can add some instruments in the front here. There's still a little bit of room, and then you'd come up here and you would, if you were picking packs, you would have 250 degrees. It would
pressurized for 30 minutes. And then you would have a 30-minute vent dry. If you were just doing the pouches, that's these without any of the packs, you would have a 270 degrees for about 5 minutes with a 30-minute dry time. You want the pressure in the autoclave to reach between 15 and 27 pounds per square inch. And the temperature range is exactly that. It's going to be between 250 and 270 degrees. Once a week, we wipe down everything in the autoclave. We take a damp cloth with some mild soap or detergent, and we will take all the trays out. We'll take these out as well, and we'll wash them, let them air dry, wipe down the whole autoclave. Once a month, however, we clean everything and wash everything down, but we will also empty the entire reservoir. We put about an ounce of Omni Cleaner in it, which is some steam autoclave cleaner. We'll put an ounce of that in the bottom of the autoclave. We'll run it on a pouches cycle, which is about 5 minutes. We stop it right before the dry cycle starts, right after it vents, and then we empty all of the distilled water out of it, refill it up with distilled water, and run it on a pouches cycle, which is 3 minutes. Or the unwrapped cycle is 3 minutes at 270 degrees Fahrenheit. We run 2 of those, emptying the water each time to make sure that everything, all of the cleaner is out and not involved in the cleaner that will be steaming our instruments. We'll then refill it up with distilled water, and it'll be ready for our next surgery cycle of instruments to be cleaned. Once a month, we also use Mesa Labs, so we send in the mail-in spore testing. We'll run a cycle with our spore test in it, and then we mail it out, and then they email our boss with the results, and so far so good. We have not had any negative results so far. Okay, our autoclave is finished. So I'll just show you the indicator strips. They say okay on them. This is a needle driver that was wrapped earlier. The needle driver has the date and the equipment written on it. These are they all have our strip has all indicated that the autoclave has reached temperature to change the indicator strip. The same thing with the tape. This is what it looked like before. This is what it looks like after it has been autoclaved. And the desired temperature, in this case was 250 degrees, has been reached for sterilization. And everything is labeled, has 6 months expiration date on it, and has initials. We'll do suture removal on a neuter. I'm just going to pull the suture forward and remove it. There was a little scab on his incision site, so that'll heal up nicely. I'll have them put a little Neosporin on it, but you can see that it healed very nicely and looks very good otherwise. Okay, so suture material. Parts of a suture needle would be the point, the body, and the suture attachment site. There are different types of points, different types of body, and different types of suture attachment sites. So, for example, for the points, we have the taper point, we have a reverse cutting point, we have a taper cut, we have a cutting edge. The taper point is very sharp. It would be used for things like your intestine or any of your other hollow organs, your bladder. The taper cut is tougher. It's more for fibrous tissue or cardiovascular procedures. Okay, the reverse cutting needle has 3 edges on the point with a triangular cross section that can be used for the skin or some upper layers of the abdomen. You also have the cutting edge needle. The cutting edge needle has 3 points on the point, 3 edges on the point, and it also has 3 edges on the body. One of the edges is on the inside of the curvature, which actually makes it a little traumatic, so veterinarians don't usually use that. all of the needles have different sizes. You have 1/2 inch, you have 3/8 inch. That talks about the curvature of the needle. So if you have a circle that has 8 slices in it, your 3/8 would be the curvature that 3 of those 8 slices make. The same thing for the half. A half would be the half circle. So it would just be half of the 4 out of the 8. It also depends on the aught. It has 0, 2, 3, 4, 5, 6. The 0 aught is a thicker needle and a thicker suture material than the 2 aught, and the 4 aught is even thinner and smaller than the 2 aught, the suture material. They all have different bodies. There's straight bodies, there's curved bodies, there's full or half curved bodies, there's circular bodies. The straight bodies might be used for a purse string on an anal sac, on an anus when you're having anal surgery of the anal sacs. Your full or half curved needles. There are also double curved needles. They're mostly used in large animal medicine. You don't see them in small animal medicine. The suture attachment sites, you might have eyes on some of the suture attachment sites. You might have a French-eyed needle where it has a complete eye and a split eye. So it attaches through the complete eye and then has to go down into the split eye. Veterinarians mostly use the swag needles, which are eyeless, where the needle and the thread are one, so they're combined during processing. So it's much smoother. It's much smoother when you're putting it through the tissue of the patient to pull through, rather than have the separation from the eye of the needle. Some suture material is absorbable, some suture material is non-absorbable. PDS, for example, is absorbable, Vicryl is absorbable, whereas Proline is not absorbable, and those sutures would be coming out. You would use either of these for your spays or your neuters in your abdomen. The Proline you would not use in your abdomen, you would use that in your sutures. Maybe you would use it for a lumpectomy, where you're definitely going to have them come back and you're going to be removing the suture. Absorbable sutures just means that your body breaks down the suture material. Non-absorbable just means that your body does not break down the suture material. Some suture material can actually act as a foreign body, and the reaction that your body has to it can be red, inflamed. Sometimes an infection might form. Some of the things that you're going to look at when you're looking for the suture that's correct is the placement, where you're going to put it, the patient's size, how active they are. Example, whether you're going to use 2.0 PDS for the spay, or whether you're going to use 3.0 PDS. Is it a kitten? Is it a large dog? So what kind of strength is required? And the healing potential, so how well is the tissue, how healthy is the tissue, and how well is it going to heal with the suture that you're going to place in it.